Welcome to Clinical Applications in Neurology. I'm your host, Dr. Peter Prococo, board-certified chiropractic neurologist and a diplomate to the American Chiropractic Neurology Board. Today we're going to talk simplicity. We're just going to quickly talk about how hemisphericity can be evaluated and some of the clinical aspects of what you see in patients with primary aspects of neocortical hemisphericity. I know that the audience is somewhat advanced and yet they're somewhat novice. I have to teach here to different levels of experience. So let's start off very simple. I want you to consider a left hemisphericity. When a person has a left hemisphericity, there's a great probability that they have a diascasis in the right cerebellum, because the right cerebellum has a feed-forward projection into the left brain. The left brain has an efferent copy back to the pontine nuclei on the same side, and it connects the circuit again over to the cerebellum on the left. There is also a very significant feedback from the brain down through the body, which causes a big efferent copy and a feedback back to the cerebellum, so that the right cerebellum and the left cortex are constantly communicating through the cord and through the brainstem in a major loop. So it's safe to say that an individual with a left hemisphericity has the probability of having a right cerebellar diascasis. Now, it's not always that way, because sometimes people with left hemisphericities have them for so long that they become globally hypotonic on one side, such that the gamma motor neurons that control the frequency of firing of the muscle spindles on that side are so decreased in their output that there's a global hypotonia, and then the feedback from that muscle spindle system is so poor that the feedback to the same side, cerebellum on the same side as the hemisphericity, is so poor that the individual develops a hemisphericity on the left with a left cerebellum problem. These things do tend to pop up and they can happen. Now, by the way, how do you treat those? You treat them the way you want, the way you measure them. But classically, what I've seen is that when I treat the cortex and I change the tone on the same side, the feedback comes up very quickly. It improves the level of that function on that cerebellum, such that the cerebellum on the other side now shows its ugly head, that it was the original culprit to the problem. So, what do we have so far? We got a left hemisphericity, and the left hemisphericity has a probability of promoting a right cerebellar diascasis. Well, that is to say that the right cerebellum problem could promote the left hemisphericity. They're really in a series, in a loop together. So let's consider now, first and foremost, what happens with hemisphericity. And, and just the way I would explain it to a patient, the right side of the brain has a 100% the left side of the brain has a 100% output. Now, 90% of that output comes from the area just in front and back of the central sulcus of Orlando. Okay, so you've got this whole central sulcus thing happening here. You've got the frontal and the parietal areas, and what do? They descend through the internal capsule and they cross to the other side on the left. And they control much of the voluntary action of the hands and upper extremities. So, some people get stroked out, and when their strokes happen, most of those strokes happen within the internal capsule, during where that 10% brain projection goes through. Those are the lenticulostriatal vessels, and those can wipe out those internal capsule projections to the contralateral side from the pre and post central sulcus, from the pre and post central gyri. But there's another 90% cortical function, cortical brain output, that goes where? It goes to the ipsilateral pontomedullary reticular formation. So therefore, the pontomedullary reticular formation is very, very important to us. And firing 90% of your output to that area is pretty significant. So let's take a look and first understand what happens when that pontomedullary system contracts, because it does one of four things. The first thing it does is it inhibits the ventral horn cells all ventral horn cells on that side of the body. So, inhibits the inhibition of all those ventral horn cells on that side. So what does that do? It provides a major tone on one side of both anterior and posterior compartments, doesn't matter. So the pontomedullary first inhibits the inhibition of all the ventral horn cells on that side, such that it creates a global stable tone on that side of the body. It also inhibits the ventral horn cells that innervate the anterior compartment muscles above T6 and the posterior compartment muscles below T6. What does that promote? That promotes the ability to inhibit the anterior compartments and the posterior compartments of your buttock so that you can stand up and have normal angulations of your arms and legs so that you can walk. Okay, the third thing that it does is it inhibits the IML on that side. The fourth thing is that it inhibits small diameter afferents from entering the cord and synapsing in the dorsal horn and making their way up to your cortex and causing too much stimulation on the brain. So these are the four things that the cerebral cortex does, but when a person has hemisphericity, it doesn't all go so well. So let's consider what happens to an individual with a left hemisphericity, for instance. The first thing that you're going to see is that they lose pontomedullary inhibition of the ventral horn cells. Now you get inhibited ventral horn cells. Or that is to say that the muscles on the left side of the body, globally, all of them, I don't care if they're anterior posterior compartment, all of them are weak. So you get a global hypotonia on one side. How do you see this in your patient? Well, your patient stands up in the Romberg position with their eyes closed. And what happens is the muscle spindles their gain is lessened, so they're not as sensitive. The muscles are weaker. The patient stands up, gravity's pulling them, and they tend to want to fall away from the side of the hemisphericity because of the global hypotonus. So if they're hypotonic on the left, they're going to want to fall to the right side with their eyes closed. Is it always that way? No, because they'll go for a bit, they'll contract and come back. They may overshoot, and they go down this way and they contract, but pay attention to the fact that in a left hemisphericity, they're globally hypotonic all on the left side. Now, if that's the first one. The second one is if they have lost the inhibition to the ventral horn cells in the anterior compartment above T6 and the posterior compartment below T6, they go back to this fetal posturing. In other words, they get increased tone to the anterior compartment muscles. That means that they're going to angulate at the shoulder, at the elbow, and at the wrist. That can promote tendinitis in the shoulder. It can promote epicondylitis at the elbow, and it can promote carpal tunnel in the wrist. Of course, you're going to see these, and you already are in your practice, in people that have hemisphericity. They have shoulder, elbow, and wrist problems all on the same side. They also are going to have problems in the lower extremity because the hip flexors are going to be weaker than the posterior compartment muscles like the gluteus and the hamstrings and the piriformis. So they can get significantly tight in those areas. So you may develop a greater trochanteric bursitis, a piriformis syndrome, all the way to sciatica associated with compressed sciatic nerves under piriformis musculature. Although I don't see a lot of that. I see more people dealing with sclerotogenous pain in the lower extremity, basically because of the biomechanical instability of the left sacroiliac, in this case, or the left lumbosacral articulations. They can also have problems with the knee because of the tonus of the anterior and posterior compartment muscles at that level. And of course, many of them have plantar fasciitis. Plantar fasciitis, how come? Because the calf gets tight, it draws in the lower extremity and puts stress on that fascia, and it also puts stress on the calcaneal tendon. They can also develop heel spurs. Fixing that is very important, but how do you get it fixed? You've got to pay attention to the left hemisphericity and then the soft tissues and the manipulations to change the angulation of those extremities. The third thing, and certainly important, is that if you do not inhibit the IML, then the IML rises up. And where do you see the high IML? Look in the eye. Look at the vein-artery ratio. You'll see that the veins may blot and the arteries constrict. Take the blood pressure. It's higher on the same side. They may sweat more in one armpit, certainly on that same side. They have problems with a heart rate that can either tack and beat faster, or it can be arrhythmic. Somebody with a left arrhythmia like me, or left hemisphericity, can develop an AFib, which I have. So you can develop arrhythmias based on the left IML rising closer to threshold, and the left IML causes what? Well, where does it integrate to? It integrates to the left AV node. The AV node controls basically the rhythm of the heart. So the left hemisphericity, there's a probability, not always, but a probability that you'll have problems in the rhythm of the heart. In a right hemisphericity, when the right cortex and the right IML rises higher, should I say, that connects to the SA node, and you may wind up with faster beating heart, so a tachycardia, or a variation of either of or, but I just wanted you to remember that. So as the IML rises first thing you want to look for is the brain's not working the way it's supposed to, and you have a hemisphericity on the side of the high IML. Last thing, and very important, is when you lose or decrease the ability to inhibit small diameter afferents from entering the cord, people begin to corticalize more of their sensory environment. What happens when that takes place is that they can be very confused and daydream quite a bit, kind of lost, looking out the window, not sure what's going on, and at the same time they can be depressed because if they're not firing, if they're getting too much stimulation to the brain and they don't get a good hemispheritic firing, then they may lose the drive of the RAF nucleus magnus and that 5-HT, the 5-hydroxytryptophan drive, that serotonergic drive that inhibits that particular system. So what does inhibit the small diameter afferents is that, the 5-HT system out of the brainstem, the nucleus RAF magnus. So when that magnus nucleus drives the 5-HT system, then you're going to get inhibition of these small diameter afferents. So if a person, for instance, you were doing pinwheel on the face and they were like, whoa, wow, geez, I feel that a lot. Let's say on the left face, because the left hemisphericity, they go, whoa, what are you doing? You're ripping me. Well, what's happening is they're not inhibiting those small diameter afferents. Those are pain afferents. So when that happens, I ask them and I say, let me ask you a question. Have you been a little blue or depressed lately? Because these come with depressed states, serotonin losses, and certainly hemisphericity on that side. Yeah, as a matter of fact, I have been a little bit. Then you'll see it up and down the whole upper and lower extremity too. They may have increased sensation to pinprick on that side because too much information is getting through. So the four things in hemisphericity are the loss of inhibition or the decreased inhibition of inhibition, which leads to global hypotonia. You see that as people sway in the Romberg position. Number two, they lose or decreased inhibition to the ventral horn cells that innervate the anterior compartment muscles above T6 and the posterior compartment muscles below T6, and they develop what? They develop angulations in the extremities, upper and lower. The third thing that they do is they lose the inhibition to the IML, and the IML begins to scream. They get sympathetic otonia on the same side, increased blood pressure, increased sweat, fatigability in the arms and the legs, the vein-artery ratios are up, the pupils get bigger. These are all things that you see. And lastly, you have the loss of inhibition to the small diameter afferents. And as they get through and they go to the brain, they confuse the brain. People tend to develop daydreaming and loss of concentration and depression. And these, you can find these literally, the place I see the most is by doing pinpricks on the face or Wartenberg pinwheels over the trigeminal distribution. And you'll see that at times they're increased in their sensitivity to that. All right, listen, I know that was very fundamental, but it's a good place for us to begin, just to get our juices flowing. And every week I'm going to add something to it for literally months at a time until we start getting to real intricate stuff by looking at extraocular movements and looking at pursuits and optokinetics and the vestibular system, all the way to basal ganglionic lesions to cerebellar disorders. We'll talk about a lot of things. But what I want you to do is just embrace this, and if this is a review for you, then that's cool. But I'll tell you, the basics are really the most important. Never forget your basics of hemisphericity, okay? I want you to get to work now for Monday morning, rock on, treat your patients, get fired up on neurology, and I'll be sure to see you next week, same time, and send me your feedback on what you thought about today's video. Have a good one. Good morning and welcome to Clinical Applications 2. I'm your host, Dr. Peter Prococo, board-certified chiropractic neurologist and a diplomate to the American Chiropractic Neurology Board. Today we're going to talk about the development of the cerebellum, how the whole thing became what it is today. Also, we're going to talk about what happens with the patient when perhaps they move their head or they have some motion and they feel pretty sick. Number one, they're dizzy, they may be vasovagal, they're nauseous, they're getting facial twitching, pseudotosis, whatever. These are all functional aspects of the pontomedullary reticular formation, and there's a reason behind why a simple vestibular signal is creating this, this whole entity. So let's first talk about the development of the cerebellum. If you look back in time, we'll say through evolutionary aspects, humans were not upright. I'll just leave it at that. So let's say that the vestibular nuclei that are important in controlling postural muscle and ocular muscle, or in other words, the dynamic movements of the posture or of the spine and the eyes, that system is not as highly integrated when humans are in this, laying down aspect as it is when they stand up. So let's just say over time humans begin to stand up, and the amount of vestibular traffic from the canals into that vestibular nuclear complex in the brainstem has now increased significantly. Now, when there's a lot of traffic from these vestibular end organs, being the utricle, the saccule, and the three semicircular canals, the primary signal was so powerful onto the vestibular nuclei that it needed something to literally gate its output or to dampen it so that the incoming vestibular signals didn't result in unappropriate movements or non-smooth movements or inappropriate purposeful movements. The deep nuclei needed help. Let's just put it that way. So some billion years ago, the vestibular nuclei knew that the human organism was beginning to stand up and become more complex, and therefore it needed a buffer system or an inhibitory system. Hence the development of the flocculonodulus. The flocculonodulus is really that, I call it the mustache. If you look at the cerebellum and you look at pictures of it, and I'll show you some in a minute, but you look at pictures of the cerebellum, it looks like a big baseball and these little pieces of mustache stick out the side. And if you remove all of that hunks of the cerebellum, the outer, the larger lateral aspects of it, and you look at it as it develops, it's basically just a little strip of inhibitory neurons sitting at the backside of the brainstem, hovering over the vestibular nucleus. So the vestibular nuclei developed this first aspect of the cerebellum, the flocculonodulus, also known as the archicerebellum, or the oldest aspect of the cerebellum. So the first thing you see is that little mustache type piece of the cerebellum sitting on the back of the vestibular nuclei. Its job is to cause inhibition of the motor neurons of the vestibular nucleus. So therefore, whether you've learned this or not, I want you to know that even though much of what we studied in the cerebellum takes place in the cerebellum, meaning that there are basket and stellate inhibitory projections to the Purkinjes, then the Purkinjes cause inhibition of the deep nuclei, and the only output from the cerebellum is the deep nuclei. Well, that's not 100% accurate, because there are many inhibitory projections from the flocculonodulus directly to the vestibular nuclei. And the reason being, as I've already mentioned to you, is that once humans became upright, there was a large amount of traffic from the vestibular system that bombarded the vestibular nuclei. It was overload for that system, so there was a compensatory development, or what's the word I'm looking for? An evolutionary need to inhibit the vestibular inputs from the ear through the cerebellum. So you have inputs from the ear, fire the vestibular nuclei in the brainstem. It's overwhelmed, develops a flocculonodular system of Purkinje inhibitory neurons, which literally send their projections out of the cerebellum right to the vestibular complex, into the vestibular nuclei, in the area acoustica of the fourth ventricle, on the floor of the fourth ventricle, such that it inhibits that vestibular output. Is that important? Absolutely. So let's talk a little bit about how the input from the ear gets to the brainstem and the actual role of the cerebellum. So now you know that there are three semicircular canals. You've got the horizontal and then two vertical canals, which are the anterior and posterior canal. Their job, the three of them collectively, is to respond to brief angular accelerations of the head. That it means that if you move your head into a direction and you move the endolymph within one or more of the canals as they couple, depending on the type of movement that you produce, there's going to be a primary vestibular afferent coming from those canals. So we first must consider that any movement of the head produces a primary vestibular afferent. I'm not going to talk to you about the saccule and the utricle and the otoliths and how those work. We'll just say that for another video. It's too much to include. So we're going to talk about angular accelerations and movement of the head create what? a primary vestibular afferent. It's the first and most important thing I want you to know, that you have a primary input from the canal. It fires into the brainstem and it synapses on one or more of the four vestibular nuclei. Okay, get the medial, lateral, superior, and inferior. Once that signal synapses there, it then sends a secondary projection back into the cerebellum. That's called the secondary vestibular projection. That secondary projection from the vestibular nuclei is en route to the flocculonodulus, to all of the Purkinje inhibitory neurons of the mustache of the cerebellum, the oldest piece, that's sitting on top of the brainstem from the posterior. Its job is to then reflex out an inhibitory signal to the vestibular nuclei. Why does it do that? To dampen the input from the vestibular system. Why is that important? Well, if you were to turn your head, for instance, you can see my eyes as I move my head in all different directions. Once I move my head and I fire the vestibular system, I fire my primary signal to the vestibular nuclei. Then I get a secondary projection over into the flocculonodulus, which sends a message now back to the vestibular nuclei, and it dampens and inhibits the initial increased activation from the vestibular system. Why do we need that? Because it coordinates the eye movements and makes them appropriate. It also coordinates the postural movements, the spinal muscles, and makes them coordinated. Listen, if you spin over and over and over and over and over in one particular direction, and you fire the heck out of that whole vestibular system, what happens? You get discoordinated movements not only of the eyes, where you get nystagmus and feel dizzy, but you're also going to get these postural disrelationships at the time, which result in what? Boop, you fall over. Can't spin like crazy, stand up and not fall over, because your postural muscles are inhibited. So it's very important for us to understand that the vestibular complex of the semicircular canals, primary signal into the brainstem, into the vestibular nuclei. The vestibular nuclei send it to the flocculonodulus of the cerebellum. The cerebellum sends the message back, inhibits the messages that came from the original source of the vestibular semicircular canals, and dampens the vestibular nuclei, sending then a message up the ascending medial longitudinal fasciculus to the ocular muscles, and down the descending medial longitudinal fasciculus to the postural muscles, so that you get a compensatory activity of the eyes and the posture, which are directed as a consequence of the vestibular canals. But if there's a goof in the link, you're going to have some problems. So hold on, because I just want to quickly show you some. In this picture here, you can see the anterior canal is illuminated in green, and the primary vestibular afferent coming from the cupula within inside of the semicircular canal is directed towards the central nervous system and synapses on the vestibular nuclei within the brainstem. This is the primary vestibular signal. This picture here is just relatively the same, but from the pure anatomical aspect. You can see the right labyrinthine system sending primary projections into the vestibular complex, or the vestibular nuclei, which are those big blue blobs on the right side of the screen in the pontomedullary system. What you should begin to think about immediately is the effects upon the pontomedullary system that can take place from increased activity of the labyrinthine system, secondary to a loss of Purkinje inhibition from the cerebellum to this pontomedullary system. In this picture, you get relatively the same thing again, where you see the vestibular canals sending their primary vestibular projection to the vestibular nuclei in the brainstem. What has now been added above it is the long mustache that I mentioned to you, which is literally the flocculonodulus of the cerebellum and all of its Purkinje inhibitory neurons. So what you're about to see is a projection from the vestibular nuclei to the flocculonodulus. That's your secondary vestibular projection. In this final illustration, we have made the complete loop circuit. Or in other words, the flocculonodulus, which is that long horizontal bar in the middle of the screen. The flocculonodulus and its Purkinje inhibitory neurons return the secondary vestibular afferent message to the vestibular nuclei, inhibiting it, therefore allowing appropriate smooth movement of the eyes and the spinal musculature systems.